Welcome again. As I said, my name is Jamarah Amani, and I am going to share a little bit with you all about National Black Midwives Alliance and what we're currently working on. Can everybody see that screen where it says National Black Midwives Alliance? Thumbs up, yes. Okay, thank you. So National Black Midwives Alliance is your professional association for Black midwives. We've been in existence for 2 years now, and we have been working on several programs. One of those being these webinars that are educational opportunities for Black midwives. We had one a couple of weeks ago, March 31st. I guess that's been almost a month already. Time has been flying. Black Midwives Town Hall on COVID-19, and then today we're discussing best practices and current guidelines. We also have our mentorship program, which the deadline for applications is this Friday, May 1st. And we encourage all Black student midwives to apply and to be matched with a mentor. We've heard lots of feedback from students that not having mentorship, not having another Black midwife that they're connected to or that they can go to for support, even outside of their regular clinical setting, is something that's a challenge. So that's why we came up with the mentorship program to help increase the support for Black student midwives and to help folks get over the hump of midwifery school or preceptorship so that we can have more Black midwives. And so that, like I said, that deadline is this Friday, May 1st. So please apply if you're a student midwife. Also, the thing that I'm most excited about right now that I've been working on for the last week is our PPE for Black Midwives campaign. I actually have one of our kits here. There's a picture. But I spent the weekend kind of starting to put together these kits. So our goal is to send PPE to 100 Black midwives, and we currently have the funding to send kits to 40 Black midwives or advanced students. So also students who are attending births, particularly managing births, and need PPE. Our kits, let me go to the list. I'm gonna switch screens. Oh, got more people joining us. Okay. I'm just gonna take us to the application. Okay. Can y'all see that COVID-19 giving campaign on the screen? Okay. So our kits include a pair of washable shoe covers, one N95 mask, a cloth mask, paper bags to store masks for reuse, a rain poncho. They're long sleeve with fitted sleeves, and they're long for wearing for PPE for births, and those are reusable as well. One pair of sterile gloves, also a pair of water birth gloves, a 3-ounce hand sanitizer, and a face shield. The value of the kits is around $50, and we are asking folks to just pay for shipping, which is less than $10. I estimate that's going to be around $8 for shipping. And so the application is at everydaybirth.com /giving. Everyday Birth is our sponsor. So they gave us a large donation to help with the cost of the kits, and the application is on the site. So you just need to put in your name, mailing address, and what type of midwife you are, what's your practice setting. Like I said, students are also encouraged to apply for a kit, and then how COVID-19 has impacted your practice. It's optional to upload a photo to be included in the campaign as well. So I'll post the link in the chat, but folks are encouraged to apply, and we'll be getting those kits out in the next 2 to 4 weeks. Okay. So thank you again to everyone who has joined us. A couple more folks jumped on. In the interest of time, we're going to go ahead and get started. I just want to remind everyone on the call that this is a space for Black midwives and student midwives. So please respect those boundaries and exit the call if you are not a Black student midwife or midwife. Hagi is going to make a presentation. Hagi's going to introduce herself, and she's going to make a presentation to us about current guidelines and recommendations regarding COVID-19. And then we're going to hear from two midwives, Kiki and Lodz, about how COVID-19 is impacting their practice. If you have questions that come up, feel free to drop those in the chat. There's a chat box where you can put questions. And we will have a Q&A at the end. But if you feel like you're going to forget your question, or if you just want to go ahead and ask it now while the presentations are going on, you can feel free to drop those questions. Okay, so that being said, Hagi, I'm going to turn it over to you. Let me know when you want me to do the screen share again.
You can do it again now. Thank you, Jamarah.
Okay.
We'll just start at the one with all the pictures. And welcome everyone. Thank you all for being here. I am with Jamarah. We have co-founded National Black Midwives Alliance, and we're so excited to be holding these types of spaces for us all to be in community together, learning and sharing and discussing, really, especially as things are sort of gray. You know, in this moment, there are definitely points that we can hold close and use for advocacy tools and just to inform our practice, but there's a lot of space for interpretation too. So let me back up. Okay, my name is Haguerenesh. My nickname is Hagi. My pronouns are she and hers. And I'm in Georgia right now. I'm Ethiopian, first generation Ethiopian. So I grew up, I'm Ethiopian Californian. But I've lived all over this country on both coasts, the South and out of the country as well. So as Jamarah said, this is going to be me just presenting to you all the guidelines that we thought would be practical and useful. This is not exhaustive. This is not all the guidelines that exist, but they are ones that we hope will be useful in your clinical practice. Let me go down. Oh, I also wanted to say about our Midwife Mentor Project. We're calling out to students, midwifery students and mentors. If you're someone who'd like to be a mentor, we really would love to invite you into the program because we have a lot of students. We always have so many more students than we have mentors. And thank you to our existing Lodz was our mentor last year and will be a mentor with us again. Maybe Kiki too. So we'll just come back to that. Let's see. Oh, I also wanted to do a quick disclaimer that we, like I said, are presenting this information for your clinical decision making to help inform, but this is not us telling you do these things. And as the new evidence continues to evolve, we'll try to keep updating ourselves and each other, but we just wanted to make clear this is information to digest and use as you will in your practice. All right, so let's go to, I just love that picture. I wish that picture could just stay up and I could just keep presenting, but we should probably go to the next slide. But wait, before you go, there's Lodz on the left, Kiki's here in the top picture with the white sweater and all the swag. Mama Saran, Mama Nasra, and her student are on the bottom with the brand new baby. That picture's from Thursday, and Jamarah's here with the face mask, with the head wrap as well. So just the beauty that we hold. I love this picture. Okay, the next slide, please. Jamarah. Thank you. Okay. So this is a screenshot for today. I don't know if folks are aware of Johns Hopkins has like an ever updating database website where you can see what's happening in the world. And so as it stands, there are 3 million total coronavirus infections. US is at the top for confirmed cases. Italy's at the top for confirmed deaths. And I don't know if you can see very clear, New York is at the top for tests. They've done the most tests so far in the world. So we just wanted to share some of those numbers just to get a sense of where we are. And you can also see from the map where there's the most density. Okay, you can go to the next slide. So what we know that US is the global epicenter. We know that disproportionately this affects our communities, communities of color. This is not new, just like all the other pandemic epidemics. We know that these disparities that have gone on for generations merely get like amplified when we have these type of health crises because they're systemic problems. On like the superficial layer, we know that people of color, we hold more of the essential jobs. We have more, statistically speaking, comorbidities, chronic illness. And then there's the structural and medical racism that definitely impacts who's getting tested, who's getting thoroughly assessed, and the quality of care that we receive. We know that testing is absolutely necessary for us to even understand what the real numbers are, like what's really, really happening and where, and that testing needs to be accessible and accurate. Staying home is as important as ever. We see what's going on in the country with different folks, you know, and there's a feeling of wanting to get out, and we get that. But in terms of reopening states and reopening establishments, we haven't, I know here in Georgia, we're steadily increasing. And so we cannot do that yet because we haven't seen the climax. And so that whole idea of flattening the curve is as important as ever. And it's hard when the weather is getting nice and, you know, all of this, but you can still go for a walk. And I'm talking to you, I really shouldn't be talking in a different tone probably because we're practitioners and we get that, but it's the conversations that we're having with our patients, with our clients. We also know that the first case was in February, not March, and there's speculation as even to before that, people remembering they had this crazy cold, this thing that, you know, just kind of putting together. So as far as what's official, they're saying the first case in the US was in February. We know that. And then the other thing that we know is that we all need immunosupportive plans because it's understood that 80% of people who are exposed with the coronavirus will get over it. Our own immune systems will combat it and take care of it. And so we really want to all make sure that ourselves and our clients are amping up our immunosupportive plans. And that goes for pregnant women, of course, too, because we know that pregnant women are not at this time, research-wise, considered at any greater risk than the general population. Okay, we can go to the next slide. What we don't know, so we don't have conclusive evidence on vertical transmission, which is, you know, passing it from pregnant mama to her baby in utero. They're trying to get more and more information around that, but it's inconclusive at this time. There's speculation and debate over whether it really is a droplet transmission is via droplet or if it's airborne, because we know some research is telling us that it does stay suspended in air for hours at a time. And so if that's the case, then that does by definition make it airborne. And so should we be taking different precautions? We don't have an effective treatment out, like, you know, that's another point of research where people are kind of looking at how with SARS, they were able to use a particular antiviral. And so seeing if that antiviral can be used in this case, or if they can tweak it a bit and use it effectively. We do know that anti-malarial medications is not the answer. So someone should call the president. But so we don't have the effective treatment. The other thing is accurate testing and implications. I kind of spoke to that on the other slide, whereas we really need the testing to be accessible to everyone, and we really need to be confirming cases so that we can have accurate numbers, and also so that the funding and the movement can go to the hotspots. And so I'll leave that at that. Vaccine, there's a big race right now to see who's gonna come up with the vaccine first, but of course there are implications with the vaccine. Like I read earlier, yesterday that they think as soon as the summer, one article, which is bogus to me, but then Bill Gates talking more about 18 months, 1 year. The question is what will happen, how will it be enforced, and who will get it? The other questions we have are around adaptive and herd immunity. So with the testing, you can test for the virus, right? But that's when we're going in through the nose, the nasal cavity, and going up to get our samples. You can also test antibodies. And so adaptive immunity is really talking about the people who've already been exposed or have gotten it and gotten better. Adaptive immunity would mean their protection. So we don't actually know, like, are they protected? Like, is that it? Are they going to stay protected, or does that immunity wear off? What is the antibody level that a person needs to be protected? All of those are questions that they're trying to figure out. And then there's the question of how many people need to have been exposed before we have herd immunity. And so scientifically speaking, when 70% of a population is exposed, then there is herd immunity. And so there's like a safety that we'll all have together so that elders can come out. We won't be as, we won't have to be as vigilant, but it's unclear. I heard one, a prime minister from the Middle East telling his people just 3 to 4 months at the gate when this whole started, when it all started, like, everyone just be patient, 3 to 4 months, and then we will be at that 70% mark and we will be able to come out again, which is of course very different than the way this country's operating with little bits and pieces. I also have a family member who's living in Sweden where they have they have more flexible regulation because they actually want people to be going out and exposing each other as long as they are not the high risk people so that they can get to that herd immunity quicker. And so those are just ideas that we're still figuring out what to think about. So next slide, please. Okay, so what officials are doing. I live in Georgia. So that little side post, I don't know if people have seen that, and I don't know if elders are on the line, so I wouldn't say what it means, but that was addressed to Governor Kemp just around, what are you doing? Like, why are we reopening? Why are we reopening bowling alleys? Like, is it that serious? Like, do people need to bowl that bad? And hair salons and barbershops, and then who's working there? You know, there are questions, and we're really trying to, you know, send the message that it's still important, very important to stay home. And so you can see on the map, the green are the places that have had the partial reopenings, which are Georgia, South Carolina, and Oklahoma. And then you can see the others in the light yellow will be opening up on the 30th, or their orders are expiring, and then the other states are shut down and restricted. One good example that I actually wanted to share, I don't know if folks have heard, in Michigan, they've created a coronavirus task force to look at racial disparities specifically, because I believe it's about 14% of the population that is Black, but there's over 40% of the population that have been, they've had deaths related to COVID-19. And so they're really looking at trying to get those numbers and get them accurate, but they're also looking at increasing transparency and reporting racial and ethnic data related to the spread of COVID-19, removing barriers to accessing proper physical and mental health care, both in the pandemic and following it, reducing the effect of racial bias in the medical industry, specifically in testing and treatment, mitigating environmental and structural racism that contributes to Black and Brown residents being more exposed during pandemics, resulting in the risk of death, and creating and improving systems that support long-term economic recovery following a pandemic. So that's just, I just wanted to highlight the example because they're really going for like the bigger, the deeper, the bigger bite around, okay, we need to mobilize, and they're putting funds behind it, and government officials. So we'll keep looking at that and see what happens. Hope other places follow suit. Next slide, please. Okay, so the research. Research is limited because we just don't have the data on pregnant women specifically. So there's databases that have formed, and I'll talk about one of them in one of the next following slides. But we really need to we need more evidence-based data. At this time, a lot of the data that we have is really case study oriented, and so there's only so far you can go with that. But to date, there's no evidence that pregnant people are at any higher risk of COVID infection, and there's no data that COVID infection early in pregnancy leads to loss or miscarriage. at this time, most of the research is really on third trimester infection and then what happens as a result. So we can go to the next slide, please. So, okay, practice guidelines. I just wanted to show where I got a lot of the information that we'll be sharing. So CDC, ACOG, RCOG, which is, so ACOG is the OBGYN, basically professional association. We're all familiar with CDC. RCOG is the equivalent of ACOG, but in the UK. And Royal College of Midwives is kind of the, I couldn't call them the equivalent, but their ACNM we know is the Nurse Midwife Professional Association, and Royal College of Midwives. They're not just nurse midwives, but they're our equivalent in terms of their the way that they follow sort of the model of OBs, but they really do their best to keep it midwife oriented. So all of these places are constantly updating the information that they're putting out. And so with CDC, we saw the most recent guideline was this month, where they changed from where they were talking about separating mom and baby, but now there's this shared decision-making and clinical decision-making on a case-by-case basis. And I'd be interested to hear from you, Lodz, on how that's playing out and the nuance with that. The assessment algorithm was just updated on the 24th of this month. All of these were updated this month. And ACNM has a list of resources that, that apply to midwives and pregnant populations as well. So we can go to the next slide. So to date, there's been one systematic review, which is considered kind of the gold standard of research, where they look at all the studies that have been done and give you kind of the summary, and we use that to move forward in research. And so the most common symptoms that they saw moms having was fever and dry cough. As I said before, all of the birth outcomes that are listed below were taken from people who were in their third trimester. So there was, at that time, there were no maternal deaths. The ICU admissions, 3 out of 108 pregnant women in the study were admitted to the ICU. There was 92% C-section related to fetal distress, but we understand that fetal distress is a real thing, but how it's interpreted can, when people decide to cut, can be different in different places. Preterm birth, about 42%. Stillbirth, 1 out of the 87 newborns, and neonatal death, 1 out of the 87 newborns. This is the study where they said, is there vertical transmission, because the baby did show up positive, but that baby was tested 36 hours postpartum. And so there's question around, like, you know, we can't say that that came just from mom, because that baby came in contact with healthcare workers, with other people. Contamination could have been from any of those other sources. So at that time, when this review was done, there were no maternal deaths, but now, as of today, April 28th, there have been 2. So on April 11th, there was a 30-weeker who passed away in Iran from COVID-19. And on April 17th, Mary Agyapong, may she rest in power. She was actually a 28-year-old Nigerian British nurse, and she was 8 months pregnant, and she passed away. Her baby survived her. They were able to do a C-section and save the baby, but she was a nurse. She was actually home, and her husband was home because he had COVID symptoms, so he was on self-quarantine, and they speculate that she got it from him. Okay, we can go to the next slide. Oh, I'm sorry, before I move on. On the right side, that's a registry. It's called the priority study, that clinicians are being asked to present their information, send their information, so that they can build up the database around what is actually going on with pregnant women and pregnant people, infections, outcomes, all of that. And so, and we see this beautiful Black woman on the cover. I was surprised that a lot of the resources, I saw brown and Black people on the covers of things. So that was, you know, I have feelings about that, but she's beautiful, and this is the priority study. So I would encourage you all to look into that, especially if you have data that you'd like to submit. Okay, so next slide. This is an ACOG bulletin that came out, I believe, last month, Jamarah. Yeah, so Jamarah's nodding her head. So it's important because we can use it as, again, as an advocacy piece or just to refer to, because OBGYNs have actually, it's stated here very clearly that they need to be working with us. They need to be working with midwives who are certified and whose licensure and education meet the International Confederation of Midwives global standards of midwifery education. And so that's that collaborative care, you know, there's a culture, right, with collaborative care. So you can tell someone to do something, but the culture can negate that. And we, you know, we hope we have practitioners who are able to move, but this is something to reference if you need to, because it's in the best interest of our patients. And so this is on the ACOG. You can find this on the ACOG website if you look up clinical information, physician frequently asked questions. Okay, next slide. So these are this is a mix of practice guidelines. As we go into the other slides, it'll kind of get more specific, but as it stands, according to CDC, pregnant women that are suspected to have COVID or have symptoms of COVID should be prioritized in testing, but that testing is still at the discretion of the clinician or their local and state health departments. So infants with suspected COVID-19 infection require isolation from other infants. So like I was saying in the previous slide, like just because the infant requires isolation doesn't mean that that infant has to be taken away from their mother. And so that bonding is kind of becoming, you know, it's being prioritized, at least in speech. And so, but the infant itself does need to be in isolation from other infants. If mother with known or suspected COVID-19 and her baby room in, then the mom should have on a face mask and practice hand hygiene, washing hands before each breastfeeding. And clinicians are encouraged to report known suspected COVID infection to the priority study. Okay, we can go to the next slide. Okay, so this is around risk screening. The one on the right is the ACOG. I don't know if it's kind of hard to read, but it's the ACOG algorithm, and it's really kind of establishing, is this pregnant woman infected and or is birth imminent? And so that's kind of how the decisions are made, and they categorize high, moderate, and mild risk. And so that's pretty dense, and I didn't know if it was as applicable. So we went ahead and adapted these other guidelines from the Health Foundation guidelines that I think are more clear, and it breaks it down by section. So for people who are doing in-office visits, then only clients are allowed to enter into the office for appointments. And if you're not there and the staff are not ready to see you, then you're advised to wait in your car until you're notified that you can come into the office. Upon entering, you need to do hand sanitation. You'll be asked a series of screening questions before you're able to enter in to your appointment, and social distancing is enforced. So patients are advised to stay home if they're sick or not feeling well, and or to call to reschedule after their 14-day quarantine, self-quarantine. So that's for prenatals. This is all under risk screening. So virtual telehealth, you know, I have a schedule that I'll share in one of the following slides. Telehealth has become a thing, like a real thing that we need to use, and we need to use judiciously. So the idea is that the same amount of information and care will be bestowed to our patients, but that there'll be fewer opportunities for contact and transmission. The in-person visits should be the initial visit, or a visit between 10 to 13 weeks, another one at 20 weeks, 28 weeks, and 36 weeks and beyond. Postpartum, there'll be a 24 to 48 hour visit and a 6-week visit. So it's important to highlight, and Jamarah made this point, that we want people to know, it's important that clients know that they still have access to their midwife, and then if they want to come in, they can, and if they have questions and need support, that they can still reach out to their practitioner, especially in our communities where there are like dynamic needs and that open door is really important. We just want to make sure to protect ourselves and our clients. So for persons in labor, if you're in labor, you're only allowed one partner, no exceptions, and it needs to be the same person that stays for the entirety of the labor and the birth. As far as doulas, a doula can be there, but they need to be trained and they need to be able to show proof of certification in order to enter into the birthing space. They may be asked to wear personal protective equipment, and that equipment will be provided to them. No support persons will be allowed to enter the birth center if they're exhibiting symptoms. So that could be partner, that could be doula, that could be anyone. And that's to protect the birth center staff. Okay, next slide. So this kind of brings it all together in terms of mitigating risk and reducing risk by not allowing any of the following to enter the clinic. So if you've traveled outside of the state that you're in or internationally in the past 2 weeks, if you've had contact with someone who has traveled outside the state or internationally in the last 2 weeks. And so these are important questions to ask, right? If you have contact with someone who has tested positive for coronavirus or suspected to have coronavirus, even if you are not symptomatic, that's another reason why you would not be allowed. And that kind of brings up that pre-symptomatic, asymptomatic debate that's out there as well. We're finding from the research that it's really that most people are pre-symptomatic. And so that's where testing comes in. If people are expressing to you that they have had contact with someone or that they've traveled recently, understanding what the local testing options are and referring them to get tested. If you have acute respiratory symptoms, dry productive cough, chest congestion, labor, breathing, etc., I added on here loss of sense of smell or taste, because that's one that I know the birth center that I'm working at here, they really talk about a lot, and it's just actually been added to the CDC list of symptoms to look out for. There's also skin rash. If you look up corona toes, there's lots of pictures. And so that's important when we're thinking about families and if children who are having new rashes, and kind of keeping that in the back as a differential or something to just keep in mind that it can present. And we know it can present many, many different ways, but those are ones that are coming out more and more. And fever, of course. If you've had a fever, temperature over 100.4, then you will not be allowed to enter into the birthing space or the clinic. Okay, so those were all, as I said, from the Health Foundation guidelines, but I also looked at RCOG just to see how they break it down. And they said prenatal, in terms of prenatally, women, pregnant mothers should really exercise social distancing, especially at 28 weeks, because as I said, most of the research is looking at birth outcomes of people who are later in their pregnancy. And you should ask about mental health at every visit. So I know I'm a nurse midwife. I'm sorry, I didn't say that in terms of my credentialing. Nurse midwife with like a home midwife, home birth midwife, everything else. So so mental health, I mean, we kind of are in tune with with clients, and you're talking to them all the time, but that mental health check is really important right now, because we know that there's so much, and there's so much PTSD people are going to be experiencing after this, and that for people who already had shaky situations, things have gotten much more intense. So prenatally also reducing, so the idea is that you want to decrease the time in the hospital. So how that plays out is that in RCOG's guidelines anyway, they're actually encouraging increased outpatient inductions. And so as it stands for folks that are practicing already out of the hospital, I'd love to hear in the case studies, or if people have shares on what you're doing, how you're doing it, if it's changed. The idea in the hospitals that they want to reduce elective induction, and so really encouraging folks to figure out how to stay away until you're in active labor, which isn't new, but in the COVID crisis, it really is heightened in terms of importance. So intrapartumly, universal risk screening should be done at all admissions and maybe repeated every 24 hours. Masks should be worn by everyone on LND units and all pregnant people when care providers are in the room, and that's to protect the healthcare providers. Again, RCOG is the OBGYN association out of the UK, but their stuff is just so much more clear. Hospital policies regarding doula partners may vary and change. You should call ahead to find out where you're going and who you can bring and what you can do, especially in the cases of transfers for those of you who are practicing outside of the hospital. Their guidelines say avoid birthing tub if suspected or confirmed COVID-19 infection. I'm going to go into the water birth guidelines from the Royal College of Midwives and Water Birth International in the following slides. But as far as they're concerned, they advise against it. Postpartum, they advise keeping mom and baby together after birth. They recommend breastfeeding, but mom needs, same as CDC in terms of mom needs to wear a mask and have proper hand hygiene. And that if a family suspects that they could have COVID infection, that they should stay at home postpartumly 14 days and infection control. But if that was the case, of course, the midwife would, she still needs to check on the baby, but telehealth would be implemented and protective gear would be worn. Okay, which is standard. We can go to the next slide. Okay, so this next one is from Water Birth International, and in our last town hall, I know that link was shared and people were talking about it. In general, the recommendations are to test when possible. If you have a woman presenting and she has no signs of infection or history of exposure, you can go ahead with the birth pool according to standard protocols. They encourage keeping a hands-off approach and not letting anyone else into the tub. They also say considering 30 milliliters to 2 tablespoons of household bleach to add to the birth pools. If you have a question about water contamination or the quality of the water source that you're using. If your facility cannot make available PPE, then they say don't offer water birth. And so that's from Water Birth International. You can go to the next slide, please. Royal College of Midwives, as far as March 2020, these were what they said. Similarly, you need to screen all women in early labor for symptoms of COVID, which includes, taking her vital signs on admission. If she has symptoms and she's had them, they say in the last days, I would speculate in the last week to 14 days, that you want to advise that patient not to do water birth due to the potential risk. They say the midwife should wear PPE and adhere to social distancing. They talk about long gauntlet gloves, which are basically the shoulder length gloves. And Jamarah was talking about the poncho. The idea is just to make sure to cover the arm all the way from the tip up to the arm to the shoulder, since with water birth, we know we'll be leaning in and there is that risk for contact contamination. Also to reduce procedures. I like the next one. It says the midwife wearing PPE is likely to become very warm. So she should have access to fluids to drink and regular breaks. I have never seen anything like that in any standard guideline. So that's that. It may be beneficial to have a second member of the team to write notes because the midwife's gonna be kind of busy. That's also really good just to maintain infection control measures, which is also very thoughtful and considerate. And that the woman will be asked to leave the pool after birth in the 3rd stage, which is not new, and enabling the midwife to assist with birthing of the placenta. I have one midwife friend and she was just saying, this is not the time to be casual about body fluids. I almost made the slide just say that, but we have to be careful. So that's from Royal College of Midwives. Can go to the next slide. Okay. And so This is in regard to telehealth specifically. ACOG put out a bulletin in terms of guideline that most states you need to be licensed and you may require a facility credential to do telehealth, that they advise insurance carriers should provide clear guidelines on making sure that folks are getting covered, that these appointments are getting covered by their insurance, that providers need to have all the equipment they need to do telehealth effectively, that they must comply with HIPAA. And I kind of talked about this before, just that with all of that being said, it should be clear to patients that one, they can come in if they really need to, and also educating them on the warning signs of being at home and what they should be looking out for. There's also educating them on immunosupportive items. So me and Jamarah were talking about this, and she made a good point, because people are going out to the stores infrequently, it'd be good to prepare your client in advance with things that you think that she might need or that she could use. So Jamarah talked about probiotics, just other herbs that you use, red raspberry leaf tea, things that you think will support her in caring for herself, her body, and whatever's a part of your practice, and that you can maintain communication with her on how to use it effectively. I believe there was a slide, unless it got erased. Okay, so I had some technical difficulties. It looks like I lost the slide, but it was about the equipment that you want to get to suggest that your clients have on hand when you're doing telehealth, so that they can monitor themselves. Where is it? Okay, well, we'll move on here. So virtual visits and telehealth, I'm sorry about that, my computer crashed. So this is just a table that I got from maternal fetal medicine, but it's actually just very clear in terms of in-person OB visits. And it's not that different than the birth center guidelines that I've read before, whereas the initial visit, optimally before 13 weeks should be done in person, 20 weeks, 28 weeks, and 36 weeks and beyond. The other visits that you can see where the ultrasounds happen or the comments are there, those are not actually visits where the midwife needs to, like for the ultrasound or to draw labs, things like that. That doesn't need to be an in-office visit. We'll go to the next slide. So these are CDC's guidelines on PPE. And so PPE includes the N95 respirators, face masks, eye protection, gowns, and gloves. KN95 are functional alternatives to N95 masks. And I believe that just has to do with where they're produced in China. And so they are marked with the K. So use when respiratory protection is strongly indicated. And that's really considered aerosol procedures. And so in some places, birth is considered an aerosol procedure because of the contact with body fluids that is possible. But in the hospital, standard is, intubation or things where you're going to be having contact with the contents of the airway. So you definitely need to use an N95 mask in those cases where you think there will be that contamination. But if you're not doing that, then they really suggest using face masks instead. And that's why we see a lot of like the homemade masks and people using the other, not the N95, but just the cloth masks. I mean, if we're considering it a droplet transmission, then that should be suffice in protecting you. So proper donning, removal, and storage. There are some great pictures of this on the CDC website. It's really important that we're not contaminating ourselves, especially if we're reusing our masks. Extended use is favored over reuse. So it's better to keep your mask on for a long time than to be taking it off and putting it back on, again, because of contamination risk. Single user only, you're the only one who should use your N95 mask, and they don't recommend using it more than 5 times. In the next slide, we'll talk about proper storage and all of that. So in regard to practice guidelines around hand hygiene, hand washing should be done for a minimum of 20 seconds. You know, in our household, we just say do the ABCs twice with our kids, but whatever is going to make it stick for people to actually see the suds and doing it properly, teaching clients to do it properly so they can see the bubbles and are getting in the creases, and or hand sanitizer that has at least 60% ethanol or 70% isopropanol is important. Okay, we can go to the next. In terms of recommendation with hand washing or a sanitizer, everywhere it says hand washing is preferred, but the idea is that if you're not gonna, people aren't gonna do that, then they need to be using sanitizer. And in the hospital, that's way more convenient. So the reuse recommendations from CDC around the masks is that you need to get rid of the mask if you have done an aerosol generating procedure. Like I said, that's really has to do a lot with the hospital sputum induction, like intubation, going into the throat. Basically, all of those are aerosol generating procedures, bronchoscopies, sputum induction. They are likely to cause more surface contamination. So you want to prevent that. You should consider use of a cleanable face shield, like I was saying before, if you really are not at that level of risk with contamination from respiratory particles. Do you want to, so when you take it off, you want to hang it in a designated storage area, or you want to keep it in a breathable container. So brown paper bags is a great option, and label it and make sure that no one else is touching it. Clean your hands with soap and water before touching or adjusting the respirator. Avoid touching the inside of it because that will contaminate it and you'll have to discard it. Use a pair of clean, non-sterile gloves when getting the respirator and putting it on, and you need to, while adjusting it and performing a seal check. That seal check is really very important. And after it's on, you can throw away the gloves and keep going from there. I'm sorry, I'm trying to rush now because I'm like, how many slides do we have left? No time. Okay, so we're coming around the corner here. So the next one is on cleaning and disinfection. EPA has an approved list of disinfectants against COVID-19, and they also give a recipe on a bleach solution that you can use to clean surfaces. All high-touch surfaces need to be disinfected frequently. And again, I'd love to hear from folks in practice, like how often you're doing that, definitely between patients. I know that that's not really feasible or realistic in, especially in hospitals where you have like this high turnover, but I'd be interested to hear how people are dealing with disinfecting, how hospitals and birth centers and things like that. If you have suspected COVID infection, it's really important to close off the areas visited by that person and increase circulation, waiting 24 hours before you go in and clean. Like, I don't know if that's an option in all places, but that's, again, these are the CDC guidelines for cleaning and disinfection. Next slide. So this is more on that. Do not shake laundry when removed. Wash in the warmest, hottest water possible. You can wash contaminated things with non-contaminated clothing. And so that's, you know, for people who are coming into the house or coming into a shared living space, you know, as soon as you can, getting through the door, taking off shoes, taking off your clothes, putting it into a bag, getting it into the washer with hot water. You can wash it with other clothes, but that's really very important. Always cleaning hands after glove removal. Okay, so my time is up. Okay, so I think this is the last slide, but you can see as it says, and these things are all on the CDC website. It's actually one of the clearer and shorter guidelines around cleaning and disinfection, because those things we've known. Okay, so we're gonna go on to our case studies, which hopefully is just gonna be a way that we can like put all this information together. I'm sorry, I know it was a lot. So first up, we have beloved Lodz Joseph, who is based in Albany, Georgia, and she is a hospital-based midwife, nurse midwife. And I will pass it to you, Lodz. Thank you.
No, thank you for that. I was listening to much of that and going, oh, we do that. Oh, we don't do that. Ooh, all right. So my name is Lodz. I'm a midwife in Albany from New York. I practice at a federally qualified health center, and then we have a separate set of privileges in the local hospital. Albany has been in the news because we have the highest per capita rate. I think right now it's just in PBS in the US, technically. So even though it's a rural area, our deaths and positive cases are making national headline. And so as of this time, we are not seeing that many positive patients. In our clinic, we have about 10 positive patients, but when we go into the hospital, the way it works is you have the patients you take care of that are in your clinic, and then we have a day where we rotate county call. So that's if an unassigned patient walks through the door, a practice automatically gets that patient depending what day of the week it is. So I say that because there's going to be a little bit of context in this case study. So the person I'm presenting is Lodz Joseph. She's a 31-year-old African-American female. She's a G3, now P3, postpartum, week 4. Had to change some information for HIPAA, of course. She started prenatal care in October. She's had approximately 14 visits. She has a history that's significant for morbid obesity. Her BMI is about 60. She has a history of preeclampsia. She currently has gestational diabetes that is uncontrolled. She's under the care of midwives, doctors, and she is in co-management with the local maternal fetal medicine doc. So her past medical history is significant for some ovarian cysts, but really it's, you know, GDM that she's had in every pregnancy. Her social history is not significant. She has an allergy to an antibiotic. We could just say Eflex. So she presented to labor and delivery reporting abdominal pain. And upon exam, she was found to be in labor. COVID unknown. Where I currently practice and where we have privileges, they are now doing a 2-hour rapid test. So upon admission, if you are found to be staying for 23 hours or more, they will automatically swab you. And so she was found that her strip, she ended up having a category 3 while she was in triage. So she was an emergency C-section and they swabbed her. The surgeon, the attending I was on that day, went on to perform an emergency C-section because she had a category 3 strip. It was really scary to actually look at it. It was no bueno, period. You know, there was no gray area. And they automatically swabbed her as they were getting ready to go in the back. So during the surgery, her swab comes back positive. So you have to just think, the mindset is everyone should be using PPE, right? Well, yes and no. You have a category 3 strip, everybody was just rushing. So everyone was actually not in all the PPE that they needed to be. Patient was immediately intubated. And after the surgery, and after they were on PACU and they were stable, they were extubated without problems. Postpartum, day 1, the way it works is that technically this becomes a doctor patient for about 6 to 12 hours. And then technically I'm on call for a 72-hour shift. So this patient was going to be mine in the morning. So I was just aware of what was going on with them. So I went to visit them, and some of the questions that we have to ask is, known or potential exposure. This patient had 2 potential people that they were exposed to that were positive, and then like 2 other that were unknown. I placed an internal medicine consult with the COVID task force team that we have in the hospital. And so they immediately manage that part of her care. So we are responsible for the obstetrical part of her care. So she was placed on prophylactic treatment. The part that was really concerning, she was tachycardic, and up to the highest was maybe 135. So, and then it resolved within 2 days. So got back down to like 98 on room air. Trying to think what else. I think honestly, the most significant thing, and I just said it out of order. She went on to have a baby that was about 10 pounds, and she had a C-section at 37 weeks. The patient admitted that they were lying about their blood sugars, or they were not truthful about their blood sugars. So at 37 weeks, 10-pound baby, I mean, you do the numbers, but they admitted that they weren't recording truthful blood glucose levels, and you see something like that. So yeah, the baby was about 10 and a half pounds at 37 weeks. So we had to kind of deal with a little bit of that, but the patient did admit, they weren't taking their medication, and they weren't, just forthcoming with like blood glucose levels, which, is kind of, I don't know, sets everybody up for, some, I guess, not the best relationship. I like to think of our care as a relationship. And so it's really hard to be putting all your trust in a relationship and not getting anything back sometimes. So this patient has been discharged from the hospital. We've reviewed signs and symptoms, things that they need to be concerned with. Now, because of the history of preeclampsia, we definitely know that COVID and people that are pregnant postpartum mirrors preeclampsia. We've seen that out of Boston. We've seen it out of, I definitely know Boston, New York, and talking to a few midwives, I think in like Virginia. And, very quickly, these preeclamptic symptoms look very different. And you go, oh, you're not dealing with preeclampsia, you're dealing with COVID-19. So it's just something to be on the lookout for. So this patient was sent home, and we really wanted them to be monitoring their blood pressures. And because we didn't want them coming back, normally a patient like this would see for an incision check within a week. And because of blood glucose levels and potential blood pressures, we'd see them 2 to 3 days after surgery, outpatient. And we did initially virtual visits. And so far that has been working, and that way we're not bringing a positive patient back into the clinic very frequently. It's also not their first C-section, so they do report that they kind of remember what some of the signs and symptoms are when it's time to go back to the hospital. So we're kind of working on that. But that was the patient that I wanted to kind of bring to you. And of course, because she has a history of GDM, we will do a 2-hour GTT at her 6-week visit. So yeah, the few things I wanted to say. When I am in the clinic, fortunately, I have access to N95s. I also went ahead, bought some masks. So I have these. I also have surgical masks. So the surgical masks, sometimes I have some in the 2 rooms where I see patients. So I'll have this and I have something else. These, I'm fortunate, I have a washer dryer right in my house. So my routine is I come home, I take everything off, I get in a shower, I wash everything. So that hasn't been a challenge for me. And so as a result, you know, I think I don't have to think about COVID fatigue. I'm just in a routine. Like, these are the steps that I do as soon as I wake up and as soon as I come back from work. And Haggy, I know you mentioned like, you know, COVID 28 weeks, 3rd trimester, that's where we're doing everything. And really, we have patients. Another case is we have people who have been positive for about a month and a half, and all you're doing is tracking them. So we have a patient who a month and a half was positive. Yeah, early March. So now it's the end of April. They just tested positive again because the hospital re-swabbed them. They were eventually discharged, but you know, everyone's thinking, what do you do when you have a patient who tests positive? There has to also be a question of what do you do for patients that are just remaining positive, because those patients still have to be seen antepartum, as well as IP, as well as postpartum. So I don't think it's like a snapshot thing. There will be a moment where we'll have to think, okay, we are probably managing someone for about 4 months with a positive COVID result, and what do we do? So yeah, if you guys have any questions, I welcome them. And Heidi spoke about cleaning. I just wanted to say, so because I don't know, I guess because I'm who I am, I like working out of the same rooms. So everything's organized. I just went through this like organization thing in the 2 rooms that I see patients. I prefer to see them there. I feel like I have more control over what I clean, what my nurse cleans, the cleanliness of the rooms. Honestly, we have a cleaning company that comes in the evening. I could tell you there are days I come in, I look under my desk, and there's like just dust bunnies and like a bunch of crap. And so, you know, you can only imagine the rooms probably aren't being mopped, they aren't being swept the way they should, and they're definitely, without a doubt, not being disinfected. So that's just the reality of where I practice. So I think it's more important for me to be slightly OCD. I go in with my Clorox wipes and wipe what I can without, you know, just being that person that's like extra. But that's what it really feels like some days. Like, you're the only person on the team that's saying this is still important, this is still a thing, you know, don't succumb to that fatigue. That's it. I'm gonna let Kiki go just in the interest of time and everything.
Hi everyone, my name is Kiki Jordan. Can folks hear me? Put a thumb up if you can hear me. I am a licensed midwife and I am a certified professional midwife in California. I am the former director of a birth center here in California, the Marin Family Birth Center. And until October, excuse me, that's where I worked. And then I transitioned into private home birth practice. And just as I was growing that practice in partnership with my midwife partner, COVID hit. And I just want to add that a part of that practice is moving into a physical space, which we're calling a prenatal center. And so as soon as we started preparing for that and signed the lease for that, COVID hit. And the way that it has changed our practice is, obviously it slowed down that progress or that project of moving into the physical space, but it also, I just want to shine this positive light on it for a moment. It also drastically increased our already growing practice, and we started seeing a significant number of Black women that were interested in having out-of-hospital birth and who had been thinking about it. There was quite a few people who inquired about home birth because they were grieving the loss. I'm sorry, let me take a step back. In California, when the hospitals decided to implement social distancing and the shelter at home mandate came down, they decided not to allow doulas to come into the hospital. So people who were planning to birth in the hospital were only allowed one support person. And that inspired a lot of people who were mourning the loss of their birth team to consider home birth. But there were also a lot of people who had been thinking about home birth, and this really inspired them to sort of do more research and push past whatever concerns or fears they had about home birth. So I had to just share that because I'm really loving that I have like a 98% Black practice, which is awesome. And it's people who are really educated about this option and making a really informed choice. I think I'm going to just talk a little bit about the way that our practice model has shifted. We already were providing in-home care for prenatal and obviously the birth and postnatal care. We shifted to doing Zoom visits, and we are keeping the same sort of routine schedule. And we are seeing people in person once per trimester. So once when they initially sign up with us, if they're in the first trimester, once at between 24 to 28 weeks, once at 36 weeks, and then, sorry, so I said once every trimester, but at the end, we're seeing long she's gonna last. Hey, somebody. The standard is here, but let's come to Tornadoes, there's no angle. Okay. We're seeing folks every other week after 36 weeks, so I'm sorry, that was a little bit confusing. At postpartum, we're doing the 24-hour visit in person. We're doing a 3 to 5 day postpartum visit in person, and then the other postpartum visits we are doing virtually. As far as PPE goes, so we're having a conversation with folks before we arrive for those in-person visits to kind of screen and make sure that there isn't one who is showing any signs or symptoms of coronavirus. We're also checking in with ourselves. And then we are wearing masks and gloves throughout the entire visit, disinfecting after every use of a piece of equipment, including our computers and our phones. And then at the birth, I just have to be honest, it just gets real. Like, we're doing our very best to keep our distance, especially when we're having water births. We've decided to increase our PPE by wearing the face shields during water birth. We recently ordered the shoulder length gloves for water birth. I have recently started wearing a separate outfit for the birth, or a separate pair of scrubs or whatever for the birth, and taking that off before I get in my car. And then when I arrive at home, I'm leaving that outside. And I'm leaving it outside for as long as I can. I used to leave it outside for 3 days, and then I'm taking it in, washing it, and putting it in the dryer on high heat. I do want to just also share that we are reusing masks because we have to. We don't have enough masks to change them often enough. And so I have various different types of masks, like Lodz was saying, for different things, for prenatals and for births, et cetera. The other piece I just want to add, one last thing before I go into my case, is that what we are seeing that's been really challenging is getting folks to get the wraparound support services that they need. So childbirth education, lactation support, therapy. If we have babies that are malpresenting, using alternative methods to help get babies to shift has been hard. Trying to explain that to families over, Zoom or virtually has proven to be a little bit challenging. But it is also giving us a lot of room to grow in the way that we educate folks and connect with folks and just look at midwifery a little bit different through a new lens. So the case I'm going to share is a 26-year-old woman who is a gravida to para 1. She is 18 weeks pregnant, and she called me 2 weeks into the shelter in place to say that she was spotting. And we had a conversation about the spotting as we were conversing. The spotting increased to bleeding, and I decided to go and see her, wearing my protective gear. And when I arrived, I was able to get heart tones, but when she went to the bathroom, I noticed that her amniotic sac was presenting. So her membranes had spontaneously ruptured. I listened and I was still able to hear the baby, and so we went to the ER. When we got to the ER, we were met with crazy hostility. I had to separate from her, and I always describe it as that scene from Color Purple where the sisters were me and you. And anyway, it was really, really painful for both of us because we were deeply emotional. We were having this kind of curious moment of trying to understand what was happening with her pregnancy, and then all of a sudden we were separated with a lot of hostility. And she was in tears and I was in tears, and so she went into the ER, and I immediately called her and just spent time on the phone with her while she was in the waiting room. The beautiful thing is that she saw an OB who ended up being this brother who had heard of me and immediately started giving her the most respectful care that I could have imagined. And he actually suggested that she schedule to come back for a D&E, but that she go home and see if she would pass the pregnancy spontaneously. And I was really pleasantly surprised. I waited for her until she came out. We went home and she was able to pass that pregnancy at home. Some of the challenging ways, though, that aside from getting separated in the ER, it's been really difficult to find emotional support for her, spiritual support for her, to have family kind of around her during this time. She's really isolated. And while we have done some in-person visits postpartum, this virtual check-ins just aren't enough. That's the story I wanted to share. The other thing I just wanted to add is that when we're working with our families, and you all talked about this a little bit, but we're really encouraging that our families sort of treat themselves like they have already been exposed. So doing a lot of immune boosting, trying to reduce sugar as much as possible, drinking anti-inflammatory teas like peppermint tea, or taking turmeric, drinking turmeric teas, and then doing things that boost your morale and your spirit. So lots of movement, lots of prayer, lots of dance, and lots of laughter. Thank you.
Thank you so much, Lodz and Kiki, for sharing those cases with us. And it really does highlight how it's just a dynamic situation where you know, you have to think about protecting yourself and trying to stay sort of present with like what you're wearing, how you're preventing contamination. But then of course you're focused on your patient and what do they need in the immediate, how do you support them? I really appreciated hearing from you both. We're gonna open it up now for, okay, Lodz, yeah, Lodz is gonna say one more thing and then we're gonna open it up for questions from you all. If you have a question directed at a particular person, please include that in the chat and you can post there. Lodz, yeah, you're welcome to say your one more thing. And I'd also ask like what your takeaway was from your case that you shared, like if there is a certain takeaway in dealing with that.
The thing I wanted to say is what was nice as Kiki was talking, I was thinking, I should also let you know, for us, it is business as usual, even though we are in a pandemic. So we have been told from our organization that we have to see as many people as possible on our panels. So because of money. So, you know, it is still a business. And so I am trying to get full panel. A full panel for me is seeing at least 20 patients a day. So if not, I'm not a productive provider. So, you know, which might be like a little different from other people. So I'd welcome, and I just wanted to say that. Were you, Haggy, were you asking the question for me, my takeaway?
Yeah, because I feel like you shared a lot from that case and just the dynamic in your hospital, but I wondered, you know, since you are talking to like all kinds of practicing midwives and students, if there was a particular takeaway that you wanted to impart.
My takeaway is I'm done with like subpar screenings. You do not have to have a fever. It's BS. Like making sure everybody is checked for this fever. I mean, that's great, but you know, wearing a mask, I mean, there are times wearing a mask, drinking coffee. You know, generally I'm lucky to have access to N95s. So I wear them all the time. And our call culture is if I'm on call and have patients, I'm in and out of the hospital. So sometimes I'm like running from my car. So, you know, all of a sudden I get a little warm with all that carbon dioxide. So I take my mask off, kind of get my breath, and then they take my temp, and my temp is like a temp like 1 degree lower. So I'm like, I know I'm not getting anything. Not to say it like that, but I'm like, I don't have a fever. Like, I don't have a fever. I don't have a fever. It's because I have all these layers on. The hospital's really cold. I'm in Southwest Georgia. It's about 85, 90 degrees. I was like, give me a second. I'm going to sip on water, not my coffee. So I would say, you know, the takeaway is the screening, because in our clinics, we only screen for temperature. And then we ask the fever, shortness of breath, the dry cough, shortness of breath. But Albany, again, sort of in culture, people are still touching each other. People are still hugging. So, you know, one of the people who was positive was like, she specifically said in this case, when I was asking her, she said, they tested positive, but I was never close to them. And I always remember that, because she was like, I was never close. They weren't in my face. But the idea that they were like over here or there, she was like, that's not in my space. So just, yeah, I think that's the way I take it. We need to be testing more people. And in Albany, we are testing less people. Yeah, so I think I don't really trust the numbers at this point.
Okay, yeah, thank you for all that. And I'm surprised to hear that Albany being what it is in terms of a hot spot for infection and that being a known thing. So Also with the social distancing, I think that gave people the illusion that 6 feet is cool, a little bit closer is okay, but really we know it's like 20 and 24 feet to really prevent like sharing the same air. You know, 6 feet was just what they felt was enforceable. So